So we have a 65-year-old female and she's admitted to hospital with increasing shortness of breath, weight gain and lower extremity edema. There's a history of hypertension, nonischemic cardiomyopathy with ejection fraction of 30%. Definitely this is a very, very low ejection fraction. Hyperlipidemia is there. Well, she's taking oral aspirin, digoxin, oral furosemide also, metoprolol, lisinopril and atorvastatin. Well, as she had been hospitalized now, so she's given an intravenous furosemide, which is a very potent diuretic. And 3 days after hospitalization, she has 6 beats of white complex ventricular tachycardia. And when we examine the patient, you find the edema has already reduced, got reduced, and the lung field is clear. That means definitely she has been much benefited by the therapy, especially the furosemide therapy which was given in the hospital. Now, at this moment when we are getting ventricular tachycardia, what's the most appropriate next step in the management of this patient tachycardia? Lovely question. But the answer to this question is C, major electrolyte level. Why is the answer? Well, now this patient experiences recurrent ventricular tachycardia, VT is ventricular tachycardia. Okay. Once she had been stabilized, the patient is to search for electrolyte reason. What is the reason why she has developed? Okay. So most likely she has electrolyte imbalance due to diuretic. We started intravenous furosemide. Okay, furosemide we started. And now this IV furosemide, it can cause hypokalemia. It also lead to hypomagnesemia. There are two potent electrolyte imbalance which can be caused by furosemide therapy. Now, before I go to the next point, I have a question for you. Well, ultimately, we got ventricular tachycardia, okay, VT, and the ECG. Let's presume that before we start furosemide, the ECG was normal rhythm. Normal rhythm means like this. We got it. So now my question is, before it really go to ventricular tachycardia, what ECG changes can occur due to furosemide therapy? Write down the answer in your copy. Well, the answer is, in this we get prolonged QT interval. This is the QT interval. And here we are getting prolonged QT interval. This prolonged QT interval, which can occur in both due to hypokalemia and hypomagnesemia also. Now, this prolonged QT interval can go to arrhythmia, so-called torsades de pointes, which can go any moment into ventricular tachycardia. So that's why ultimate reason is due to hypokalemia or hypomagnesemia. Hence, the best answer of this is we measure immediate electrolyte, so that if the problem is there, we can do the correction. Okay. So it can lead to ventricular tachycardia, as I told you. And moreover, one more thing, hypokalemia potentiate the side effect of digoxin also. And don't forget, patient was already taking digoxin as a home therapy. Now, hypokalemia is going to potentiate toxicity of digoxin, which can induce ventricular arrhythmia. So we got one more reason why patient can have a ventricular arrhythmia. So what to do in this case? You order for electrolytes. Now you are clear about it. Why electrolytes, especially potassium and magnesium, and also serum digoxin level. Now I have one more question for you. Well, if electrolyte imbalance is there, we do the correction. Slowly we give potassium and magnesium also. But my question is, suppose the electrolyte level are normal and the serum digoxin level is increased. That means it is the digoxin toxicity which is causing these arrhythmias. Now, what shall be your line of management if the digoxin level is high? The answer is you have to give digiban, which can take care of the digoxin level. So we have to give digoxin binding antibodies so that we check or control the level of digoxin in the blood. Okay, specific indication of FAB is when some arrhythmias like this which are happening due to digoxin. Well, let's look into other options. Spironolactone is a potassium sparing diuretic. Patient is already on diuretic therapy, okay, and it has a definitely mortality benefit in a patient with congestive heart failure. But at the moment, our aim is to find out the reason of arrhythmias. So it's the first thing you add is to do the testing of electrolyte. Okay, because even if you add spironolactone, it's not going to take care of the hypokalemia within minutes or hours. It will take time. But low potassium level can produce ventricular tachycardia any moment, and patient will have a cardiac arrest. So this doesn't stand anywhere. The best answer shall be electrolyte. Okay. Same thing, metazolone is again the type of thiazide diuretic. And it is a very powerful, out of all thiazide diuretic, it is one of the most powerful thiazide diuretic. And moreover, there is no indication of adding any diuretic because already leg edema is reduced, lungs are clear. That means his congestive heart failure problem has been taken care. There is no point in adding, and it is further going to cause hypokalemia, and it is going to worsen. So it will add to ventricular tachycardia. So there is no point in adding another diuretic. Discontinuation of atorvastatin. Atorvastatin has nothing to do with arrhythmias. Okay, it's a treatment for hyperlipidemia. No way it is related to arrhythmias. So there is no point in stopping. You continue with atorvastatin. Discontinue metoprolol. Beta blockers should be avoided in decompensated congestive heart failure because of systolic dysfunction. Okay. Moreover, patient congestive problem has already been improved. So this and moreover, metoprolol does not cause ventricular tachycardia. So there is no advantage of stopping metoprolol at the moment. And so by rule out technique also we can say very comfortably we are confirmed. We are clear that why we should go for electrolyte checking, serum digoxin checking, and do the needful accordingly. The golden line to remember: loop diuretic can cause hypokalemia and hypomagnesemia. These electrolyte abnormality can cause ventricular tachycardia and also potentiate side effect of digoxin. So we have a 56-year-old man, and he's brought to the emergency department with severe crushing mid-sternal chest pain, and there is diaphoresis and some shortness of breath also. 10 days ago, he underwent coronary angiography, and that revealed 90% of the stenosis of the proximal left anterior descending artery, and which everolimus eluting stent were implanted. Echocardiography at time of discharge was normal. Past history of hyperlipidemia, type 2 diabetes, obesity, and gout is there. At the moment, BP is normal. ECG shows tachycardia with 2 millimeter ST segment elevation in lead 1 to 3. Okay. Well, most likely cause of the patient current condition is. If you review the question again, point to be noted is, well, the type of pain chest he is, most likely it is having MI, most likely. Well, it has been further supported by ST elevation in V1 to V3. That is again supporting that he has got ST elevated MI. That's clear to you. But more important is he got stent in the left anterior descending artery, which supply the anteroseptal area, which is supplied by V1 to V3. Okay, and again, you are getting ST elevation in V1 to V3. Same artery where stent was put. Now again, we are getting re-infarction in the same place. That is the point that we have understood till now. So with this background, we look into the option. The right answer is medication non-compliance. Why this? Why not others? So as I just told you, there is acute ST elevated MI in V1 to V3 due to proximal descending artery stenosis, occlusion, so-called LAD, occlusion is there. Rather, there is a re-occlusion is there. Cushing, mid-sternal pain, chest, which is the classical feature that we see in a case of acute MI. Dyspnea and diaphoresis are usually seen in acute MI, and ST elevation, as I told you, that can reconfirm that we are dealing with precordial leads V1 to V3, which supply the anteroseptal. So in this patient, they put a drug-eluting stent, was put in LAD, but again that restenosis is occurring, and this is most likely due to subacute stent thrombosis due to medical non-compliance. It is a very, very important point. What is that? Well, stent thrombosis is a potentially fatal complication of a coronary artery stenting, like in this patient. So whenever we put a stent, long-term dual antiplatelet therapy, okay, what we call as DAPT, dual antiplatelet therapy, DAPT, should be given. And one of the drug is aspirin, and any other platelet P2Y receptor blocker, clopidogrel, prasugrel, or ticagrelor. In fact, this is in actual practice, this is the most widely used. That means these two combinations are most widely used as a dual antiplatelet therapy. And this is to reduce the risk of stent thrombosis after intracoronary drug-eluting stent placement. Well, which drug are used in drug-eluting stent? One is everolimus, which was there in our question also. Now write down the answer. Name other drugs that are used for drug-eluting stent. Well, the answer is sirolimus and paclitaxel are the other drugs that we use for drug-eluting stent. Well, so we were talking about that in any patient where we have put a intracoronary stent, DAPT should be done. Premature discontinuation of antiplatelet therapy is the strongest predictor of stent thrombosis within first 12 months. But in this case, the problem happened within 10 days of putting a stent. That means, and it is such an important point that DAPT should be continued minimum for 12 months. And in our case, it happened in 10 days. And every patient should be screened and counseled regarding medication compliance to reduce the risk of stent thrombosis. So quite possibility that in our case, patient did not have the compliance of the drug, and that lead to restenosis of the same artery, so-called stent thrombus. Now let's look into other option also. We use the rule out technique also. Acute pericarditis. Peri-infarction pericarditis can occur within days of recent MI, maybe 2-3 days also. And this is characterized by pleuritic pain chest, pain in the trapezius ridges, and it is not squeezing pain. The character is not squeezing pain. And moreover, when we are pericardial friction rub is always heard, and that is a specific sign. And there is no such rub is there, so we can very comfortably rule out. But if the pericardial friction rub is there, that's a specific and highly suggestive of pericarditis. Okay, but this is not in our patient, so we can rule out comfortably. Moreover, the diffuse ST segment elevation occur in the entire precordial lead, not only V1 to V3. Like in our case, it is V1 to V3. Okay, so this again not supporting, but definitely this is much more specific to diagnose pericarditis. Okay, then option B, aortic dissection, is incorrect. It typically presents as a tearing pain chest, not the crushing pain chest that we get in acute myocardial infarction. And moreover, it always occurs when uncontrolled hypertension is there. But in our case, the BP is normal. It shall rule out the possibility of aortic dissection. And normally, aortic dissection does not lead to ST elevation unless it had extend to coronary artery. Otherwise, ST elevation in ECG is not a finding. Okay, so this again ruled out. Now, one strong possibility of atherosclerotic plaque rupture. In fact, it is the closest differential for the question. Okay, well, this we can think in the present clinical scenario. Yes, it is a strong possibility. But the thing is, ischemia involves the recently stented LAD, left anterior descending artery, makes stent thrombus much more likely than the plaque rupture. Okay, which would be unlikely at the site of recent intracoronary stent. Already stent is there, so that's why it's unlikely. And moreover, patient non-compliance is a strong indication in this case. The history can be taken, whether he has taken the drug or not. So out of the two close competitor, then stent thrombus is much more. Now suppose the question was that a stent was put in left anterior descending artery. Now the MI is occurring in some other artery, maybe circumflex, maybe right coronary artery. Then in that case, then this would have been the best answer. But in the present question, present scenario, stent thrombus is the better option. Well, option D, left ventricular aneurysm formation. It represents a scarred or fibrotic myocardium as a result of prior transmural myocardial infarction. Well, how does this patient present? The patient may be heart failure due to progressive LV enlargement, refractory angina, ventricular arrhythmias, but one of the most dangerous thing is about embolization. Because a clot may form like this normal myocardium. So when we get an aneurysm, so we get like this. Okay, aneurysm is there, and a clot may form, which can go into these into the aorta and can lead to systemic embolization can occur. That's a dangerous complication. Patient can end up with CVA. Okay. Well, how do you suspect? First of all, it's not an immediate problem. It's a little late problem. Usually it doesn't happen within first 10 days. Little late complication. However, we go into incomplete picture. ECG also shows persistent ST segment elevation, just like acute MI. But it is persistent ST segment elevation. If you have taken the last 10 days ECG every and whenever aneurysm is there, the ST segment will be persistently elevated. There may be evidence of prior MI with the presence of deep Q wave and T wave inversion. The same leads can be there. However, we can diagnose by echocardiography. Okay. And we should not forget the echo was normal at the time of discharge. So that possibility again ruled out. Finally, the golden line to remember: premature discontinuation of antiplatelet therapy is a stronger predictor of stent thrombosis after intracoronary stent implantation. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB medicine and family medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a for mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.